Thank you, Massimo. Good afternoon, everyone. I have to say, talking about key concepts of physiology before Jean-Louis Teboul and Sheldon Magdalene is not an easy task, but I'll try my best. And I think what I'll try to do over the next 15-20 minutes is try to give you a little bit of my understanding on how we can look at pressure and venous return. And in my research group, we are looking at venous return extensively now. I think it's a key component of understanding physiology for everything that we do. Doesn't matter if we measure cardiac output instead of venous return, because they are exactly the same thing, but the physiological understanding of it is really score to understand everything that we talk about really when we talk about heart-lung interactions. I will talk a little bit about the different mode of ventilation, because heart-lung interaction is something that happens all the time. Even in this moment in this room, no one is ventilated, but we all have heart-lung interactions. And I will show you some concept that I'm sure later on Professor Teboul will explain better in terms of systolic pressure variation, stroke volume variation, PPV, and so on. And I will touch a little bit on some new research we are doing about using these markers also to look at arterioventricular coupling. So when we talk about venous return, I will give a very, very brief overview of this. When we talk about cardiac output, often we think about stroke volume and heart rate. And then we know that we can manipulate the stroke volume by working on the preload, on the contractility, on the afterload. Now, we said that the cardiac output has to equal the venous return. That's how the Frank-Starling mechanism works. The heart is able to accommodate roughly everything that comes back to the heart in terms of venous return. If it doesn't, we have problems. We have edema, hardening in the lungs, or periphery. So venous return has to equal cardiac output. So if we use this, then we introduce slightly different variables, and we use what is called the mean systemic filling pressure, the right atrial pressure, or the CVP, and the resistance between these two. And in this very schematic cartoon, we can imagine the blood vessels to be elastic bands that we fill with blood, and there will be a certain amount of blood that does not generate any pressure. That is what we call the unstressed volume. Then we keep filling with blood this vessel, and it will depend on the elasticity of this vessel. Some of this blood will generate a pressure, and that's what is generated by the stress volume in our circulation. Now, the stress volume has got what is called the mean systemic filling pressure. Now, in any hydraulic system, in order to have flow, I need to have a gradient between 2 points. So if I have my mean systemic filling pressure, which is basically a marker of how my circulation is feeling at that moment, I will be able to have flow towards the heart only if the heart is able to maintain the CVP, so the right atrial pressure, as low as possible. And in practice, that's what the heart does. A very good heart is able to maintain the CVP as low as possible. And what Guyton taught us was that if we look at different venous return curves, still, the way that we can increment the venous return curve for the same value of the mean systemic filling pressure is actually not by increasing the CVP, it's actually by reducing the CVP. The only reason why we see the CVP increasing is when we give fluids, for instance, is because we are moving to a higher level of mean systemic filling pressure. So we're raising the mean systemic filling pressure. As a side effect, we will see the CVP at some point increasing as well. And understanding this is really key to understand also heart-lung interactions, because it means that anything that affects my right atrial pressure, whether it is cardiac performance, for instance, a patient that goes into fast atrial fibrillation, or something that is affected externally, for instance, by an increase in the intrathoracic pressure, and that's what we talk when we talk about heart-lung interaction, that will have profound effects on the venous return. So in practice, to me, the concept of trying to use the ventilation to predict the response to fluids is a bit like this. I want to understand in which part of the Frank-Starling curve I'm working. We know that for each physiological state of our patient, the venous return curve and the cardiac function curve, they can only meet in one single point. And if I am giving fluids, I am basically increasing my mean systemic filling pressure. If I'm working on the ascending part of the Frank-Starling curve, I will see then an increase in cardiac output when I give fluids to my patients. If, on the other hand, I have a poor performing ventricle, I'm already operating on the plateau part of the Frank-Starling curve, even if I give fluids, I will be effective in increasing the stress volume of my circulation, but I will not see a significant increase in cardiac output. So in practice, when we use the heart-lung interaction, we are trying to see in which part of the Frank-Starling curve we are, so that then if we give fluids, we will increase the mean systemic filling pressure, and we will understand whether or not the patient will be able to increase cardiac output. Now, the understanding of this is physiology of our specialty back many, many years. And as I said, the heart-lung interaction is something that we see even during spontaneous ventilation. And for instance, during inspiration, in spontaneous ventilation, I know that my intrathoracic pressure will go down, and then when I go back to expirate, the intrathoracic pressure will go back to the baseline value. What happens if we look at the different components of the ventricles, for instance? Well, if we look at the right ventricle, for instance, we know that this is also reflected into an oscillations of the pressure that we can see in the pulmonary artery. And also, we see that there is a fluctuation in the values of flow, so stroke volume, that the right ventricle is pumping during the respiratory cycle. Interesting enough, this is completely the opposite of what happened with the left ventricle. Now, the beauty of the Frank-Starling mechanism is that we are able to compensate for these little fluctuations in the stroke volume of the right ventricle and the left ventricle, so then overall, the venous return and the cardiac output will be equal. The nice thing about this slide and this study is that if you look even at the pressure of the pulmonary artery, you can really see all the concepts of pulse pressure variation and changes in the pulse pressure with the ventilation. What about positive pressure ventilation? Well, with positive pressure ventilation, the relationship between the intrathoracic pressure and the ventilation is completely opposite. So in this case, when I am ventilating my patient, so during an inspiratory breath, the intrathoracic pressure will increase, and then it will go back to baseline during expiration. This has got completely different effects on the circulation, to the extent that indeed we know that when we increase the intrathoracic pressure, we decrease the preload because we're basically decreasing the venous return. Imagine that we're raising the right atrial pressure for the same value of the mean systemic filling pressure, so I'm reducing temporary my gradient. But also we know that there are some effects on the right ventricular afterload and on the left ventricular afterload, and these effects are completely opposite. Indeed, the right ventricle will have, to an extent, an increase in afterload, while the left ventricle will have a decrease in afterload. And this is one of the principles while, for instance, we give CPAP to patients that are developing heart failure. We're trying to reduce the afterload of the ventricle. And this is something to keep in mind when we try to interpret pulse pressure variation or stroke volume variation, for instance, in patients that have an impaired right ventricle. And we will see this later. So if we want to give a Guytonian cut to the explanation of how the heart-lung interaction works, when I have a patient that is on the ventilator, I can imagine that there is a thoracic pump effect. I am not changing the filling of the circulation of that patient in that moment. So let's imagine I'm working just on one venous return curve. And the effect of the thoracic pump is similar to the effect of actually shifting the cardiac function curve. Now, what I see then is that by looking at the effect, if, for instance, if I'm measuring pulse pressure or stroke volume or cardiac output, I will see that if during the ventilation there is a big change, the high variation of stroke volume or cardiac output, then that is telling me that patient is probably working on the ascending part of the Frank-Starling curve. Why is that important? Because then I know that if I give fluids in that situation, I will increase my mean systemic filling pressure again, and I will be able to rise significantly the cardiac output. Now, we don't have to think about all these mechanisms of the venous return. The beauty now is that we have a lot of technologies that can do the calculations for us when we look just at cardiac output. And for instance, if I overimpose the airway pressure of a ventilator to an arterial pressure waveform, I can see that there is this swing on the arterial pressure waveform, and that means that I will be able to quantify this either in terms of systolic pressure variation or pulse pressure variation or even stroke volume variation. And if the variation is very high, then, as I said, when we will give fluids to our patients, then the patient is more likely to respond with an increase in cardiac output inflow. Now, the first experiment was an experiment done on animals by the group of Ezra Perel, and indeed the first of these variables was the systolic pressure variation. But probably the most seminal paper in terms of application at the bedside is the paper by the group of Professor Teboul and Frederick Mechard, in which they were able to show that pulse pressure variation, in this case, was very good at discriminating patients that would have been then fluid responsive to the administration of a bolus of fluid. Now, there are some limitations to this approach. And yes, the area under the curve, the sensitivity and the specificity are pretty good, but we need to know that we are ventilating patients with 7 milliliters per kilogram of ideal body weight. I admit it's not something that I do routinely. Actually, I do basically never in my practice anymore. Patient has to be in sinus rhythm, and they don't have to be in, have a respiratory drive. It doesn't mean that we shouldn't be looking at this. If I have a patient with a low tidal volume, for instance, that has got a very high variation, it's likely that the patient probably will be fluid responsive. But when I go to lower value, I cannot probably say the same thing. Now, another important concept is what we were saying before about the effect of the ventilation of the right ventricle. In normal circumstances, this is not something that is affecting too much the afterload of the right ventricle. But if I have a right ventricle that is failing, for instance, in the case of acute cor pulmonale, if I have induced a severe increase in the afterload of the right ventricle, that can become a problem. And this was demonstrated quite nicely by this study of the group of Professor Takala, in which in an animal model they were generating and producing right ventricular failure. And as you see from the area under the curve here, pulse pressure variation here was not able to discriminate well responders and non-responders. Why? It's not that the physiological concept doesn't work anymore, it's that in this case the effect on the afterload of the right ventricle is very important. So keep in mind that if we have patients with significant acute cor pulmonale, maybe we shouldn't be using these blindly. Or another thing would be that if I have a patient that has got a very high stroke volume variation, a very high pulse pressure variation, I give fluids and I don't see anything happening to the cardiac output, maybe there should be a hint that I should get my echo probe and have a look at the right ventricle and see what's happening there. We don't have to use just the cyclical changes in the ventilation to look at the interaction between the lungs and the heart. Even levels of PEEP, of course, they have an impact on the venous return. And we can use the same principle this time by releasing the pressure on the ventilator, and we can see what's happening in terms of flow. So this again was done by the group of Xavier Monet and Jean-Louis Teboul, and they were able to show that during an end expiratory occlusion test, if I see that the cardiac output of my patient will increase in those few seconds, then it's an idea that probably if I give fluids, I will be able to increase the venous return. This is nothing new. It is actually something that we knew about the physiology, and in practice is also something that we see when we have patients that are moved from mechanical ventilation to a spontaneous breathing trial. During a spontaneous breathing trial, we are decreasing the level of pressure in the pleura, and what we are doing basically is seeing this effect. We see an increase in the preload, we see a decrease in the afterload of the right ventricle, and we will see an increase in the left ventricular afterload. Why is it important to understand this? The majority of patients usually they're able to tolerate pretty well an extubation, but some of our patients they will fail an extubation, so they will fail weaning from the ventilator, not necessarily from a lung pathology, but due to the fact that the heart is failing, due to the augmented preload effect and to the effect on the afterload. I'm going to conclude, just show you another couple of applications of these concepts. With a Spanish group and a group in London, we started to look, also now we can couple the ratio between the stroke volume variation and the pulse pressure variation. The idea is that if we look at how the pulse pressure and the stroke volume change over the respiratory cycle, we can basically understand in which part of the dynamic arterial elastance the patient is lying. And in practice, it means that then if that patient will increase the cardiac output, I can predict if that patient will be able to increase also the blood pressure. Now, this is a new concept. We are now validating this with different devices. The first paper in which we tested this approach was published actually by the group of Ignacio Monge in Spain, and they were able to show on a mathematical reconstruction of the curve that this was able to discriminate pretty well between patients that increase their arterial blood pressure with fluid administration and with increase in cardiac output. Another idea that we had was also this, the fact that if the spontaneous breathing is affecting the validity of one of these, probably will be affecting the validity also of the other. So we thought that maybe in spontaneous breathing patient, if we look at the ratio will still be valid. And we demonstrated this with a paper that was published last year, in which we look at the dynamic arterial elastance in spontaneous breathing patients. And this time we were able to show again that we were able to discriminate between patients that would have an increase in their arterial blood pressure and the one they would have not. Now, it's important to remember these are new concepts that we are testing. You may have noticed that the value in one study was different from the value of the other study, so we don't have external validity in this moment to use this at the bedside, but probably are some interesting concepts of atrioventricular coupling that we can look at to see whether we can use this in the future. So, to summarize, I think heart-lung interaction is always present. The venous return, it's important for me to remember how it works, because if we understand that we always have in the back of our mind what happens when we change the intrathoracic pressure in our patients. Remember that we can use stroke volume variation and pulse pressure variation. I'm sure that Professor Teboul will explain this better later. We can do end expiratory occlusion test. We are testing now new ways of looking at this ratio to look at atrioventricular coupling, but beware of limitations. It's nice to think that everything is black and white, but the truth is that physiology at the bedside is important always to remember, because there are many situations in which some of these things may be applicable and some others in which they won't. Thank you.